Well, good afternoon, everyone. We are excited. We're glad you're back. Welcome back to another session for the SOFT virtual conference. We have another great talk coming your way this afternoon, and I'm going to just get right to it. Many of you have probably been on before, but just in case you haven't, we'll take questions at the end. Dr. Carey will take questions at the end. So you can either use the raise your hand feature, or you can in the chat area write your message, and we will go through and make sure that you get them all, get your questions asked and answered. And so with that, and then we have, let's see, what do we have later? We have Dr. Braddock come back for that. But what matters is what we have right now. And I'm excited, and I know all of our families are excited to hear from Dr. Carey. Dr. Carey is with the University of Utah. I'm going to actually shorten it this time, Dr. Carey, because I kind of, last.
Please do.
He's SOFT's medical advisor. He's been with watching, and he's been studying our kids for years and years, and has, when no one else did, seen their purpose and their passion, and he's had a passion for them and their purpose, and it's just listening to him talk. I'm a little touched right now because Dr. Carey was just sharing something with us. So anyway, what I want to do right now is we're going to go out. Dr. Carey, I'm bumbling, so let's take it over to you.
Thank you, Terry. And I wanted to acknowledge both Kelly and Terry for what they've done this week in orchestrating all of these presentations. Many of you may know we had 3 presentations for medical professionals, hopefully educating many around the country, around North America, about various medical aspects of trisomy 18 and 13 and related conditions. So today I was going to give a presentation that I usually deliver at the SOFT conferences, probably almost every year since the late 1980s. This year I changed my talk somewhat, especially for those that have heard me give this talk before, and I'm going to present about half of the content to be on the genetic aspects of trisomy 18 and 13. I chose to do this because I get a lot of questions in this regard, a lot of questions about mosaicism, about partial, about translocations, even though they make up a relatively small proportion of both trisomy 18 and 13. They certainly are a big part of trisomy 9 and some of our other related disorders. But I get so many questions in that regard, excuse me, I thought that I would actually focus about half of the talk on the genetic aspects and actually present what I would call a primer on genes and chromosomes, and then spend a little bit less than half the talk on a brief, concise overview of both syndromes, here focusing on 18 and 13, not on the 9s and other conditions. And I'll close with the last few minutes with our current recommendations about healthcare supervision and follow-up of children with trisomy 18 and 13. And in a way, that's kind of a lead-in to Dr. Braddock's talk 3 hours from now, which specifically under the cloak of healthcare supervision, he's going to talk about tumor surveillance in trisomy 18. So without further ado, this will be probably a 4-hour, 2 or 3 lectures in a master's level genetics course in about 20 minutes. So for that reason, please forgive me. Sorry. Got the little frogs rising up there. So this is a DNA molecule. This is the basic framework of all of life. And I mean not only human life, plant life, fungi life, bacteria life. Zika and Corona have DNA molecules that look like this. So it's basically a twisted acid, deoxyribonucleic acid, DNA, that has these, and here they're colored, these nucleotides that even though the whole molecule is an acid, they're actually the opposite, they're bases. And there's 4 of them, and this this code of four, of these four, they're named down here. I won't go through the names, but you can see they're color coded and they match up with their partner. This arrangement of these nucleotide bases is the backbone, is the blueprint for eventually establishing proteins which do everything in our body. And the basic premise, what people call the basic law of biology, really only learned in the last 50 years, is DNA, which is replicated in the process, that is doubled. DNA is transcribed by cutting out some of the DNA into ribonucleic acid, RNA, which then forms the template, forms the backbone, forms the basic foundation of lining up the amino acids to make a protein. And these little molecules here are meant to be 3 amino acids in a protein, just as an example. And this is called the basic law or basic premise of biology. As you may know, DNA was discovered in 1953 by Watson and Crick, led to them winning the Nobel Prize. And really the rise in DNA in medicine has really only been in the last 30 years. This all relates to chromosomes because this gene, this particle that we're talking about, the twisted helix, and only about 2% of all of our DNA go to make up the DNA that makes proteins, interestingly. Most of it, 98% of it, are other elements that we're still learning about. But this 2% is primarily what we're interested in when we talk about changes in genes. But so here you have the gene at the top, the DNA at the top, that then is made tighter and is packaged, this is a very complicated process, by these other complex molecules called histones that you can see they're jam-packed, and they really put like a covering on this whole molecule, if you will, that eventually is packaged together into a chromosome. So here you actually see a chromosome that could be a number 4. I don't know for sure, because it isn't marked for us to know that. But here's a chromosome is basically this packaged DNA. In order for the genes to work and eventually make their protein, a signaling molecule has to get inside of this DNA molecule, and these nucleosomes have to open up, and that's a whole other complex machinery that we're just still learning about. So here is a chromosome study, a so-called karyotype, that's K-A-R-O, karyotype, nothing to do with my last name, karyotype. So here is a karyotype of a girl, because we see there are 2 X's over in the corner here, which defines this. We would know that as a karyotype of a female. This was obtained by drawing blood, taking out the white blood cells, and breaking open the nucleus where the chromosomes are, having them spill out onto a slide, and then separating them by an unsalted solution that keeps them separate, and then staining them, and then looking at them under a microscope, and then arranging them in an order from the largest to the smallest, with the sex chromosomes, the X in a female, and the X and a Y over in the corner here by tradition. So you remember all the genes are lined up like beads on a string on these chromosomes, just like we showed a few slides ago. These stripes or bands tell us which chromosome it is. So when the technologist is looking in the microscope, she or he immediately recognizes this is a 4 by this cotton ball at the end, by these 2 dark bands there. They know that this is a 13. You have these 2 dark bands down here, only 1 on the 14. That becomes important in a few moments. Here you have the 18, which looks different than the 17, but back in Dr. Edwards' day, we couldn't separate these because they hadn't figured out the banding pattern technique yet. So, and again, the inside the cell, all these chromosomes are meshed together and probably talking to each other somewhat. This is all an artificial lining up so that we can actually talk about them. So in 1960, they named this 1 and 2 and 3. They could have called it A, B, C, D, E, but they called it 1 and 2. And as pointed out already, importantly, this is the two 13s, and this is the two 18s. And of course, in trisomy 9 or partial 9p trisomy, this is the 9. So just to give you an idea, other than the X chromosome, where we knew about color blindness, muscular dystrophy, hemophilia, a number of other conditions, just by looking at the family tree. Prior to that, we hardly knew where any of the genes were located. But starting in the early 1980s, but it kind of exploding in almost a revolutionary way, by the 90s and the 2000s, we ended up with techniques that allowed us to put a particular genetic condition's gene on its particular chromosome. I won't go through those techniques, but now we know that there are 5,000 disease genes that have been defined, and you can actually go to a database and figure out where they are. So just to give you an idea, for blood type, Rh negative, A negative, which I am, the Rh gene is on the very tip of the 1 chromosome. Whether you're A type or B type is kind of in the middle of the long arm of the 9 chromosome. The gene for cystic fibrosis, the 2 genes, it's a recessive condition, are on the 7 chromosome. We could go on and on. One of the breast cancer genes called BRCA1 is right there on the 17 chromosome. So that work started to occur when I was already practicing genetics for 15 and 16 years, and suddenly all this knowledge exploded. I'm not going to go into more detail about sort of the gene mapping and the genes, other than that there are probably single genes that are on chromosomes that probably play a role in the physical signs of chromosome syndromes, and we'll chat about that a little bit more. So here's your basic structure of a chromosome. These cartoons are showing you an example. On the left is a number 2, and you can see the chromosomes constrict, not necessarily in the middle. You can see this one doesn't constrict in the middle. That's our 18, but here they constrict in the middle, and this is duplicated. When they're inside the cell, they're a single strand, but before division, they duplicate. So you have 2 copies. Then, of course, when we're going to make, when the cells are going to make another cell, they split longitudinally on this axis here. So when the middle constriction, called the centromere, is in the middle like this, it's called a metacentric chromosome. So the 1, 2, and 3 are the 6, 7, 8, 9, 10. They're all metacentric chromosomes. The 18 has the centromere a little bit up higher, so they call it a submetacentric. While the 13, 14, 15, 21, 22 chromosomes are called acrocentric. And that plays it, that's important to know, in the most common translocation in trisomy 13, the 13, 14 translocation, which is also the most common translocation in human beings. We'll talk more about that actually in a moment. So notice here, the centromere is almost at the top, and this DNA that's on a stalk out here, it's called the satellite, and this doesn't have any genes that do any function in making proteins that have function in the body. So so if they're missing, which they are in a small percent of people, they don't have any function. I mean, it's not really a monosomy or deletion. So here's your basic chromosome anatomy. These stripes, as I mentioned, also called bands, are due to the staining process, which you got a feeling for in the chromosome. So chromosome conditions really only came about in 1959. We discovered that Down syndrome and Turner syndrome were chromosome abnormalities. Of course, in 1960, trisomy 18 and 13 were both described. And then the field of clinical chromosome cytogenetics emerged just about the time that I was in high school, and then it advanced while I was in college and medical school in the late 60s and early 70s. But conditions of chromosomes, which is what we're interested in, and what I'm going to talk about for the next 15 minutes, are they're divided into conditions of number, trisomy, 3 bodies, trisomy, or monosomy, 1 body. Soma is the Greek word for body. So trisomy, 3 bodies, if you will. Colored bodies, which is the Greek word for chromosomes. So trisomy, conditions of structure. Here's where the change in the chromosome is within one of the arms of the chromosome. I forgot to tell you in the last slide that by convention, the shorter of the 2 parts of the chromosome above and below the centromere are called arms. And then they're nicknamed the P and the Q, the short arm and the long arm. So the P arm of the 2, the P arm of the 18. So disorders of structure are involving parts of the chromosome rather than a whole chromosome. And there's a number of conditions of structure. Every one of these can have a role in trisomy 18, 13, and partial or mosaic 9. I'm not going to discuss these other ones in detail. I'm only to discuss translocations because inversions and rings make up less than 1% of all the people we would know that would have trisomy 18 or trisomy 13. Chromosome conditions are also divided into conditions that involve the autosomes, the non-sex chromosomes, 1 through 22, or the sex chromosomes, the X and the Y. So you see these kind of 2 different types of classifications, the number and structure, and autosomes versus sex chromosomes. So there's your basic primer on just kind of looking at the overview of chromosome conditions that we're interested in kind of in general. So here's a karyotype of a female, 2 X's, with trisomy 18. So if we counted this up, there would be 47 rather than the 23 pairs times 2 or 26. So I forgot to mention that earlier, that there are in fact a total of 46 chromosomes, 2 of each one, 2 1s, 2 2s, 2 3s, 23 pairs. And of course, that was only discovered in 1956. I was in the 5th grade then, not so long ago, when we actually determined the correct number of human chromosomes. And then, as mentioned, 3 years later, we learned about Down syndrome being trisomy 21, and we learned about trisomy 18 and 13 the next year. So notice here's a cartoon of the banding nomenclature or numbering system for 18, and this kind of becomes important when we're talking about partial, whether it's partial 18P trisomy, or partial 18Q, which is the most common partial trisomy of various sizes. More on that in a moment. So it turns out by the study of partial trisomy 18, and also partial trisomy 13, and also 9P trisomy, and all the partial trisomies, we kind of learn what part of the arm or segment of the chromosome are the genes present that actually cause that particular physical finding we're interested in. So it turns out that in trisomy 18, children who have partial trisomy 18 that involve 2/3 of the bottom of the 18Q, 2/3 have most of the Edwards syndrome, but not all of the Edwards syndrome. Children with partial trisomy of one half or 2/3 of the long arm usually do not have the surveillance or the same issues about survival that we see in classical full complete Edwards syndrome trisomy 18. But even children, I've seen about 5 who involve all of the long arm of the 18Q, all of the long arm, don't have complete classical Edwards syndrome, and also, again, although small numbers, have improved survival compared to classic Edwards syndrome, which I'm sure most of you know about. One of the few physical features that we can map, well, we know that children with trisomy up here alone don't usually have heart defects, while partial trisomy down here do. So the heart defects reside from a gene or genes in this area. And we do know from one family who had partial trisomy 18 that the gene that predisposes to Wilms tumor, which Dr. Braddock will talk about, has to be on a gene that's lower than this band here, 11.2. I'm not sure Dr. Braddock will talk about that piece, but just to let you know about that. So partial trisomies of 18 only make up 1 or 2% of children that might be called Edwards syndrome. Most of the time, partial trisomy 18 causes a partial form, as I had been alluding to. But most children, then 95%, that are diagnosed with Edwards syndrome, usually in the newborn period, have full complete trisomy 18. And full complete trisomy 18 is due to a process that almost always occurs prior to conception, when the extra chromosome arises. And that process is called non-disjunction. So now what I'm talking about is not the partial stuff and translocation. I'm talking about the origin of the extra chromosome in the more typical trisomy 18. So it turns out that in order to come down and end up with a single chromosome in a sperm and an egg, in order to do that, you go through a two-step process called meiosis. Meiosis 1 and meiosis 2. We're going to call these the 18. The two 18s line up. They actually exchange material before they separate. That's called recombination. Helps make human beings even more variable, siblings more variable. And then what they do, look over on the right-hand column now, they actually separate. 118 goes this way, 118 goes that way. And then what they do is they split down longitudinally each way. So in non-disjunction, there are two ways it can happen. It can happen at the first step, where both 18s go this way, none goes this way. This conception will go on to have monosomy 18, which does not survive and usually results in miscarriage. Only partial monosomy 18 Q is actually known, or 18P. So now here's the first step. Now they split down the middle, and you have two gametes, that is sperm or egg, that actually have two copies arriving back here from both grandparents, if you will. And when the partner chromosome unites, the sperm or the egg, the then future baby will have 3 18s. In the other way, you can do it kind of the same way. Here you have the here the splitting down the middle. You have 2, and then when the partner is, you have 3. Notice here the different color coding. This actually tells us that these two processes, these two steps, 1 or 2, when that occurs, a different set of the grandparents' chromosome end up down there. I'm not going to go into detail about that, just kind of an interesting note. So in trisomy 21 and trisomy 13, almost 100% of the events occur in meiosis 1. But in trisomy 18, it's about 50-50. And we don't know the reason for that, and that may be providing a clue that we don't quite understand yet. So trisomy 13, here we have the extra chromosome, in this case yellowed in. Notice it's one of these acrocentric chromosomes, like its partner 14, where there's just a little bit of the short arm or the P arm at the end. And this is a boy, because there's an X and a Y over here, a boy with trisomy 13 in this karyotype. So over 90% of children who have trisomy 13 have full complete trisomy 13. But almost 10% have the trisomy 13 due to a translocation. And almost all of those are due to a translocation that is called a Robertsonian translocation, name for a doctor who described it, Robertsonian translocation. This is a special translocation that only makes up a proportion of all translocations in people. And we're, of course, not going to talk about them completely in detail today. So, say it again, about 10% of children with trisomy 13 have trisomy 13 due to a translocation, most of them due to a Robertsonian translocation, a smaller proportion due to a different translocation involving other chromosomes that result in partial trisomy 13. In a Robertsonian translocation, what happens is, and this is the 14 here, 13 and 14, these break apart and this unites together. There, like this. 14 here, 13 here. This individual who has this has everything balanced because if this is lost, it doesn't have developmental effect. About 1 in 1,000 people carry a 13-14 translocation. Most common rearrangement in human beings, or let's say rearrangement of concern. Think about an athletic event, of course, when we had athletic events, but think about an athletic event, number of people in the audience who could have a 13-14, and most of them don't know it. Most of them don't know it because when there is a 13-14 translocation, the actual risk to have a baby with trisomy 13 or trisomy 14 is only about 1%. So there's a lot of people with a 13-14 translocation who don't know that they carry the translocation. So this Robertsonian translocation then is depicted in this particular karyotype. Look at the cartoon over here. Remember the 13 and 14 unite at the short arms. Here, can't quite see that as well. 13 down at this part, 14 down at this part. This person has 45 chromosomes, not 46. This person is physically, quotes, normal because there are 2 13s, 1, 2, and 2 14s there and there, because this 14 is attached there. But when this person goes on to have children, depending how these 3 chromosomes separate in the junction process that we talked about, depending on how they separate, and I'm not going to go through this cartoon in just in the interest of time, but here would be sperm or egg that would end up with, quotes, normal or a balanced Robertsonian, or end up with trisomy 13 or trisomy 14. So depending how they separate or segregate, the offspring then has an unbalanced Robertsonian translocation, or trisomy 13, or unbalanced with trisomy 14. Here you can see a boy with 47 chromosomes. I'm sorry, 46 chromosomes. Slipped there, said that wrong. 2 13s, another 13, and then a 14 up here. And you may have gotten used to looking at these 2 bands here at the bottom of the 13, only one sort of deep dark band at the bottom of the 14. Here you can see it better over here with the 2 13 dark bands. The person in the lab just knows immediately, here's a 13, that's a 14. So what I just showed you would be almost an entire lecture in a master genetics course. So again, sorry for the abbreviation. The more common type of, well, let's say it's not the more common in human populations, but the one that has much more diversity is the reciprocal balance translocation, which is what is responsible in the case of partial 9p trisomy, but also partial 18p or 18q trisomy. And here you have an example here of the 1 and of the 9. You can see the darker 9, the whiter 1, where there was an exchange of a little piece of the 9 going over to the bottom of the 1, and a piece of the 1 going to the top of the 9. So this particular person has a balanced reciprocal translocation but depending on the separation of these chromosomes, the offspring can have the unbalanced version with a partial trisomy and even a partial missing piece of whatever particular chromosome we're talking about. I'm going to skip my example there in the interest of time. So we're 2 more slides on our chromosome primer, and then I'll spend the last 10 minutes talking a little bit about trisomy 18 and 13. Since you know about that, just give us framework and close with just the health supervision. So mosaicism, when I told you a few minutes ago in trisomy 18, I threw out figures, 95% have full complete trisomy 18, a little less than 5% have partial, and then the remaining, and I didn't say the number, 1 or 2% that have what people would call Edwards syndrome physically have mosaicism. And I know that much of the audience is familiar with this concept, but it is the presence in an individual of and the tissue of at least 2 cell lines that differ genetically. I mean, it could be that both of them have trisomy for that matter, but it means there's at least 2. There can be more. But it's from a single zygote, that is a single fertilized egg, sperm and egg together. And the reason they're saying that is because mosaicism is different from chimerism, which is the fusion of 2 embryos at an early stage together. And I'm not going to talk about chimerism today because it isn't related to our topic, but that's why they're putting in that part about the single zygote. So somatic mosaicism refers to the idea that in the body cells, which is what we're talking about in mosaicism, in trisomy 18, or trisomy 13 mosaicism, or trisomy 9 mosaicism, the presence of genetically distinct populations of these cells in a given organism. So a person with trisomy 18 mosaicism, and they usually record this by the number of cells, could have a karyotype that would be 40 of the cells are 47 plus 18, an extra 18, and 10 of the cells that were counted are normal 46XX, or could be a different number. And of course, that would apply to any trisomy that we're talking about. So the way that mosaicism is thought to arise is 2 different mechanisms, and probably the one on the right, prezygotic, means that the person was conceived with had a trisomy at the time of conception by the method I showed you earlier, the non-disjunction. But so had it at that time, but then after the cells started dividing, lost one of the extra chromosomes and ended up with 2 cell lines. The trisomy cell line, which is over here on the 2 on our right, or the cell lines that had the trisomy and the 46 population. So that's probably, we now think, happens most of the time when a person has mosaicism. But we also know that it also could arise after conception. So you have conception, you have 2 cells, maybe you have 4 cells, maybe you have 8, maybe you have 16, and then a non-disjunction event, like we talked about earlier, occurs, and you end up in a monosomy cell line and a trisomy cell line. And sometimes in mosaicism like this, you can actually find the monosomy cell line. Most of the time, though, you don't. So that ends the first more than 50% of my talk today, primarily on genetic, but also I do want to talk a little bit about the medical, because I would like to say a few words about health supervision and follow-up of children. That would go back, let's say, for your pediatricians or your specialists and primary care doctors, because it also does a good segue into Dr. Braddock's talk, which would be at 5 o'clock today Central Time. So let's talk about an overview of trisomy 13. This is going to be short by plan, because, of course, many of you already are well informed about the physical aspects. I'm not going to go through some of the population figures and the rest, but I'm happy to answer questions of that at the end if you want me to. So trisomy 18, the second most common autosomal trisomy. Now you know what this word means. Non-sex chromosome. Second most common autosomal trisomy after Down syndrome. The occurrence in our live-born children centers around 1 in 6,000 babies. That means there's about 600 babies born in the US per year, just to translate that, since there are almost 4 million births in the US. And trisomy 18 is a recognizable pattern or syndrome, and you're all familiar with these risks that are associated. So here's a picture that if any of you have heard me talk before, have seen me show before, and this is Dr. Edwards from Dr. Edwards' paper of the original child, whose name was Sarah. We know that because he told us her name when he came to a soft meeting in 1990, which was in St. Louis. Here's this cute young lady. She was actually a few weeks old in the picture, and she actually has this clenched overriding fingers that we now is associated. It was this child who Dr. Edwards saw in a hospital near Oxford, where he drew a blood sample, went back to his cell biologist because Down syndrome had just been discovered that year, and thought, well, maybe we'll discover another trisomy, and he did. And that's in that paper he wrote was in 1960. There is Dr. Edwards on the right. I always like to show his picture. I had the pleasure to get to know him. He passed away about 5 years ago. The woman on his left is his wife, who even about 2 years ago I corresponded with. She's also a physician in the Oxford area. This is Kyle, one of my friends with trisomy 18 mosaicism, who's now in his 30s. This is St. Louis. So the pattern most of you know trisomy 18 are quite familiar with: small characteristic hands, which I just mentioned, small breastbone, and of course the birth defects, which are the most important part and convey really the medical issues that we're concerned about. And here's a picture that those of you who have heard this talk have shown me before, and this is Carrie Holiday, and this is Rachel, the first two children whose mothers, Chris Holiday, Rachel Watson, formed SOFT in 1979 to 1980 when things got moving. Here's a young lady that I met at a Chicago meeting many years ago, who was kind enough to let me have her picture for a textbook of medical students. And again, you can see some of the physical characteristics. And there's Chris. She's probably not watching my presentation. She likes that I show this picture because she has a different hair color in this picture, but you can't miss her immediate requirement to give you a hug when we could be doing other hugs than virtual, and of course displaying her incredible smile. Trisomy 13, third most common autosomal trisomy after 21 and 18. Prevalence is about half of trisomy 18, roughly about 1 in 12,000 on average, so about half the number of children, about 300 children born in the US per year. And again, trisomy 13 is as recognizable to the newborn doctor as is trisomy 18, often more because of the cleft lip and the extra digit that occur in trisomy 13. So it turns out that Dr. Edwards' paper in a British medical journal called Lancet in April of 1960 was published back to back with the paper by Dr. Patel from the University of Wisconsin, where the first case of trisomy 13 was depicted. And they were in fact together establishing in single observation both of those conditions. The physical features of trisomy 13, over half of kids have cleft lip and or cleft palate by itself, smaller eyes, extra digit on the pinky side, and then of course other physical features. And there is the picture from the paper in Lancet in April of 1960 of the first child who did have very small eyes that were not well formed and had a cleft lip on both sides. That was the first detection of trisomy 13. And there's my friend Aaron, who in this picture is 6 or 7, I think. It's also a picture from a textbook, Aaron with his walker, and then also gait trainer, who I got to know over the years at soft meetings. So trisomy 13, like trisomy 18, a list of physical findings and birth defects that occur. I'm not going to go through the list in detail other than to highlight that, like in trisomy 18, 80% of children have a heart defect. So that's the end of my sort of very brief touching on kind of the definition, frequency, original history of the two syndromes that we're primarily focusing on today. Of course, trisomy 18 Edwards syndrome, Patel syndrome. This picture is of a beautiful young lady from Sweden who I got to know for years at soft meetings. In this picture, she's in her mid-20s. The young lady to her right is now an orthopedic surgeon in Sweden. And this family came to many soft meetings. She passed away at about the age of 30. And a few years later, they came to some soft meetings. We got the pleasure of getting to see them again, and she also came as well. So just briefly, in the medical literature, my point is that there are very few reported children with trisomy 18 or trisomy 13 beyond a year of age. In this case, we'll just pick 10 years of age. While we know from SOFT there are quadruple and more children who are older than 1 or 2 or 3 years of age from our experience in SOFT. And that's really the point. So some of these papers, we learn about children with trisomy 18 who can walk. Dr. Kosha's work in Japan in both trisomy 13, trisomy 18. But of course, we know that walking unassisted in both conditions just from our soft experience. But you'll hear people say sometimes that a child is not able to walk or speak. So important to clarify that in this context. So let me just spend the last, these two text slides at the end so we can have at least 15 minutes for questions. And I'll take questions on whether the genetics or the medical part. So the idea of the health supervision is that myself and Dr. McCaffrey and Dr. Braddock and Dr. Green and others, we've published this in different places, have made recommendations of how pediatricians and specialists would initially evaluate and then follow up children with trisomy 18 and 13. So I first published this in a peer-reviewed journal in the paper in 2012, but I had previously published it in various chapters over 20 years. But it is really meant to be almost like a checklist, if you will, for the doctors to have. So of course, in both trisomy 18 and 13, assuming that a family is choosing the pathway of intervention, say, as opposed to the other aspect of comfort care without intervention, assuming that, then it will be important to have a cardiac evaluation and the appropriate cardiac follow-up, and to have an airway evaluation by someone familiar with airway issues, especially in trisomy 18. And that, again, would occur early on, and when necessary, to have a sleep study to accompany the airway assessment to go along with that. And I think that particular message we've kind of known about for a while, but it's really emerged in the last few years, and especially with the great talks that Dr. Green has given us at the last 2 years of SOFT, and that he actually gave on Wednesday of this week to the medical professional. Of course, we all know referral to early intervention, that will be a given, important. Follow growth on the growth curves, which are available, accessible on trisomy.org. Everyone knows that I've been working on orchestrating and updating of these growth curves, and I promise that will happen. Referral to a feeding clinic or dysphagia clinic or pediatric gastroenterology person if and usually they are when feeding occurs, especially around decisions if a G-tube would be considered. Hearing loss is a common feature in both syndromes. Trisomy 18, often related to the very narrowed ear canals, but even independent of that. So hearing tests are important. There are children with both syndromes that do have usually not middle ear disease, but can have inner ear changes of the cochlea or of the nerve, and could potentially benefit from hearing aids. In trisomy 13, I think it's important to have some central nervous system imaging because of the concern for the brain difference called holoprosencephaly. Not sure imaging needs to be done in trisomy 18 unless there are seizures, but in my mind should be done in trisomy 13. Like audiology for hearing, ophthalmology, that should be done routinely early on in infancy and then follow up as needed depending on the finding. In trisomy 18, we know that difficulties with light are an issue. We really learned that from the first soft meeting. And Dr. Cantrell, who's also speaking today another time, has invented our sunglasses. In trisomy 18, because of the fortunately low but definite tumor risk for liver and kidney tumor, we recommend abdominal ultrasound screening now every 3 months. We don't know exactly when to stop. For the moment, we're picking 8 years of age. And Dr. Braddock, this is his talk this afternoon. And then follow up for scoliosis. While it does occur in trisomy 13, it's almost the rule in trisomy 18. So this is important. I'm going to skip that slide in the interest. And so here, just a group picture of everyone, a lot of the kids from 2001 in the Boston. And here's a picture of when I went to the first soft meeting in Japan, which was a quite defining and interesting experience for myself. So I'm going to stop at this point, and I did leave us about 13 minutes for questions. I know that if we go over the 13 minutes, Zoom doesn't kick us off, but I'm happy to answer any questions. And I assume, Kelly, it's like in our other talks that if someone does their hand raised, that you can actually allow someone to speak. Is that right, Kelly?
Yes, that is correct. So right now I do have 2 questions in the chat. I don't see any hands raised as of yet. So I'll start with the 2 questions that we have. The first one is from Steffi, and she says, does full, partial, or mosaic play a role in survival rate or longevity and lifespan, or more of a case-by-case dependent upon health problems?
Thank you for that question. That is really an important question, and I didn't allude to it. And maybe it would take up, I don't want it to take up our time, but it certainly children with partial trisomy 18 who have 1/2 or 2/3 of the long arm, the Q arm, we know that they do not have the same survival predictions that we hear about for full complete trisomy 18. That I can say with confidence. There are some children with almost the entire long arm that have passed away in the first few weeks, months, or year of life, but most of the time in partial trisomy 18, those prediction figures you hear about do not apply. In partial 18p trisomy, they don't apply at all because 18p trisomy, just the short arm, not the long arm, is actually a relatively mild condition that goes from a developmental disability similar to Down syndrome to learning disabilities. And thus, again, those predictions of health and survival do not apply for the short arm. Of course, the medical issues apply somewhat to the long arm, but not to survival. So mosaicism is a complex question. And when we do a chromosome study at the time of birth, or an amniocentesis, or amnio after a cell-free DNA, they'll usually count 20 cells. If you count 20 cells, that's the standard, there's a 90% probability that you have excluded a normal cell line of 10% or less. So it's a statistical situation, not a yes, no. Every time we have a karyotype in a 1-week-old, and a 3-week-old. We only get one study. They have Edwards syndrome. They have full trisomy 18 based on one study. We make our decisions based on that study. If a child survives, some people will start to go on or intervention, no intervention, whatever, goes on and survive. People will start to say at some point, well, maybe she has mosaicism, whatever. Without doing another sample, and ideally in another tissue, like maybe a cheek swab, that's the easiest way to do it, we still can't say there isn't mosaicism. It was a double negative. There could still be mosaicism in any child we diagnose. But I will say this, in my experience, and there's one British study that supports this to some degree. If a child has the Edwards syndrome, that's physical syndrome with all of its parameters that we know about, and they have mosaicism, some normal cell line, in my experience, before we started having more intervention, and in this British study, their figures are similar to regular typical trisomy 18. But I'm making that statement with not as much data as we'd like. If a child does not have typical Edwards syndrome and has, let's say, for example, they don't even think about trisomy 18, but she has developmental delay, decreased muscle tone, and let's say a ventricular septal defect. She's 4 months of age. They grab a chromosome study, and she has 80% trisomy 18 and 20% normal. She doesn't have Edwards syndrome. I mean, she wasn't diagnosed. She's different. She has a heart defect. Maybe she has something else. But in my mind, the figures of outcome are probably off because she didn't really have typical Edwards syndrome. So this, I'm really glad you asked, because it's really a complex issue, because people actually, think, well, okay, this reason, which many of you already know, if someone is 4 months of age and having difficulty in care and they have mosaicism, maybe they won't have as much difficulties in getting care. And so that might be a reason to do a second sample or to do a cheek swab sample. On the other hand, I wouldn't make the decision based on mosaicism. I'd make the decision based on the child and what issues they have and where we're going. But on the other hand, I recognize that some surgeons might treat the child differently. So again, thank you for that question. I should stop because we won't get a chance for others. Kelly, I know I think you're up to 3 more now.
I am. The next one says, my daughter has 13 to 13 translocation. I've always thought it was a random occurrence. Are you saying it's actually genetic? Both her father and I have other children who are typical.
Thank you for that question. Great question. So the chromosome that I showed you, the 13, 14, imagine that it was the 13 and 13 together. So you can imagine that the two 13s came together to form that 13, 13 isochromosome. That was a word I didn't discuss earlier, isochromosome. You gave me the key piece of information, and that is that you have other children. So your geneticist or genetic counselor probably told you that. If somebody carried a 13-13 translocation, they had 45 chromosomes, there's only 2 options. They're either going to have a child with trisomy 13 because the partner is going to add another 13, or they're going to have monosomy 13. Therefore, since they're normal children without trisomy 13, it already tells me that either you or your partner have the 13-13 translocation. So you're not at increased risk. Keep in mind, we're doing genetic counseling by video without my seeing your chromosome study, but I'm agreeing with what you heard before, that it is a sporadic event, and that barring some low-grade mosaicism, remote possibility, you're right, that it would be a sporadic event. Thank you for the question, because it kind of clarifies some of that, because I only talked about the 13-14. I didn't talk about 13-15 or 13-13.
Related to that question, Oh, wait a minute. I'm sorry. The next question. It says, is gene mapping the most accurate way to identify the specific form of trisomy? Full versus mosaicism versus translocation, etc.
Great question. So the sequencing that is done uh, is called a cytogenomic microarray. And what they do in that is they measure the DNA. So what happens is nowadays, if somebody knows that a baby has trisomy 18 clinically, or thinks, knows they have trisomy 13, they get a standard old-fashioned karyotype that I showed you early on. You do that, you do a karyotype. They count 20 cells. If there's a translocation related to partial trisomy 13 or 18, they pick it up. If there isn't, full complete trisomy 18, full complete trisomy 13, we know the answer from a standard karyotype. I already mentioned the idea that when they count 20 cells, you can never exclude mosaicism with 100% certainty. You can only exclude it with 90% certainty. And so, and I already mentioned that particular point. So a regular chromosome study is the preferred method. But this is what happens. They're in the nursery and someone grabs the more up-to-date sequencing, which I mentioned, called microarray. There, you can exclude mosaicism very effectively. A microarray does that. What you can't exclude as well is partial trisomy 18 or partial. You can pretty much exclude partial trisomy 13, but you can't completely exclude partial trisomy 13 and a translocation. So I always recommend getting a regular karyotype if nowadays the microarray was done. So that was complicated. And if it didn't make sense, whoever asked the question, and you're still wondering, please email me.
Okay, I'm going to bring on Rhonda. She has raised her hand, so give me 1 second. Rhonda, if you can, there you go. You got yourself unmuted. Go ahead.
Hello.
Thanks so much. Yeah, I'm in Calgary, Alberta, and I'm just calling because my daughter, she's 6.5, and she's had chronic respiratory problems, and she's hospitalized every year, usually between January and June. This year it was significant. She was in there 4 times. And then she's also had Meckel's diverticulum and had surgery to remove that. And so just wondered, is it hopeful that some of those respiratory issues will go away as she gets older and her airways get bigger? And is Meckel's diverticulum, is that a common thing to happen for kids with trisomy 18? So just my 2 questions.
Thank you. Those are great questions. So she's 6 years of age, and we assume, as we talked a moment ago, she has complete full trisomy 18.
Yes.
Good. Just to clarify. And then, so those infections do tend to get better with age. However, it's sometimes brought up, although it tends not to be able to occur after 2 or 3 years of age, to give the RSV antibody, RSV, I said RSU, to give the RSV antibodies. In Canada, I don't know if it's easier to get that coverage by your national health insurance program. At her age, sometimes it's able to be done because of also having heart defects at the same time. And that way we can take RSV off the table. I completely think that someone should have a flu shot, so we can take that off the table. But with time, usually you do see some improvement in those kinds of infections, unless there was something else going on that we didn't know about. It does, though, Rhonda, bring up the question that we've talked about a lot in the last few years in trisomy 18 circles, 13 and 18, and that is, do kids with trisomy 18, and it's come up in both, have an immune problem that has not yet been discovered? That is a completely unstudied area, and it should be studied. We learned in the measles epidemic going to Detroit last year that there were kids with trisomy, both trisomies, who didn't have antibodies against measles that had been immunized. And I know of 4 such examples. So they might not be able to continue to mount the antibody. Really what I'm trying to say, not, hopefully I've answered your question partly, is that we really need to study that issue more because there might be some immune problem not known. I know that there are at least 2 children with trisomy 18, a third in one of my own patients here, and 2 patients with trisomy 13 in America that gets IV immunoglobulins because of that issue. I'm not saying that your child necessarily needs that. I'm maybe complicating it for you. I'd start off with the flu shot, possibly the RSV, and keep the other kind of in mind. You might want to ask your doctor. Our immunologist here has been open to the idea, but some immunologists might not be as open. But everybody keep it on our list. You know, Terry, Kelly, we need to recruit an immunologist, and we need to get some young immunologist. And that would answer Rhonda's first question. Second question: 2% of everyone have a Meckel's diverticulum. That's a little 2 inches away from the junction of the ileum and the colon. We know that Meckel's diverticulum, that particular variant, occurs much more commonly in trisomy 18. I don't know its frequency, but because of its presence, it is a potential predisposition for an intussusception to occur. So always keep that in mind. I wouldn't get it prophylactically removed, but it's always a potential for torsion. And so if there was unexplained pain, unexplained irritability, I'd always keep the Meckel's in mind when you go to the emergency room.
Awesome. Thank you so much. I appreciate that.
Thank you.
Okay, I'm going to go on to our next question. And this is from Carice. She says, is focal nocturnal seizures common with full T18 children?
I'm sorry, Kelly, the first word was focal and the second one was?
Focal nocturnal.
Right. Also a good question. You guys are, I mean, you're bringing out the questions that could be covered. So in seizures in general, there are only 2 published papers. It's another topic that needs better review, better study. One of the papers was from Japan, and one of the papers was from Italy. And in both of those papers, they did describe the seizure pattern in trisomy 18. And I'd have to go to the papers, but I do not remember focal or nocturnal being on the list. Now the thing is, I'd have to check that though. Now the thing is that as you know, in asking the question, being nocturnal, that might make them less often be detected and yet still be of significance. And still, at least with the neurologist I work with, still often lead to therapy. So to answer your question, I don't know that it's more common. It may be that we're missing it more often than we know. I'd have to go to the 2 papers to see if it's been reported, but if it's been reported, it's still going to be a low frequency. It's hard for me to not think it's part of the trisomy, just because we know that 20 to, in the one paper, 20 to 30% of children with trisomy 18 have seizures, and a somewhat similar number, although less well known, in trisomy 13 have seizures.
Okay, the next person, Brittany, says, our geneticist said it didn't matter what size the chromosome is. Can you explain if the size matters and what the lines stand for?
The second word you said were lines?
Yes.
Right, so I suspect that's related to the stripes or the bands, and they look like lines. And on the early slides I showed you, the staining of the chromosome, the material they use for stain, goes to the proteins and DNA and makes each chromosome stain differently. So that's why the lines make the one look different than the 2. The 16 look different than the 18, and so on. So the lines are, they're named by a numbering system, which I didn't show you. It was on the slide, but I didn't go over it with you. So that's what the lines are. And the lines are landmarks. They give the geneticist or the chromosome person a landmark to say, oh, the break was at 18q21. That is 18, chromosome 18, long arm, segment 1, band 1. So 2-1, that's the landmark, which is a fairly big area when it comes to a number of genes that might be in there. So here's where the size of the chromosome comes in. If you look at trisomy, you will find every trisomy 1 through 22 seen when you study miscarried conceptions. But trisomy 1, 2, 3, 4, 5, 6, 7, essentially 8, 9, 10, 11, 12, 14, 15, 16, 17, 19, 20, and 22 are only seen as full in a miscarried individual. They're not seen in a full state. We only see trisomy 22, which is relatively well described, trisomy 9, which is relatively well described, trisomy 8. We only see them in the mosaic situation. So people have said the size of the chromosome, look, 21 is the smallest one, even though it's before 22. It's actually the smallest. It's the smallest one, and that you don't see the miscarriages as much in trisomy 21. So numbers of genes much make a difference. Well, on the other side of it, trisomy 16 is relatively small chromosome, and it's the most common trisomy in miscarried conceptions. So your geneticist is right. It's probably not so much the exact size, it's what genes are 3 copied and where they are on that particular chromosome. So trisomy 13, what we care about is the long arm, not the short arm. That long arm is only a little bit bigger than the trisomy 18 long arm. So trisomy 13, from that point of view, is relatively small. Yet the next door neighbor, trisomy 14, is the same size, yet it never results in a live-born baby because the genetic material must have genes in there that have major effects. Maybe that was long-winded, but maybe it was too much information, but hopefully it helped.
It's great. Our next question is from Carice. Are parents with full T18 children carriers of the syndrome? And also, do you feel that our children should get the COVID-19 vaccine if one should ever be found?
On the first question, there have been studies where parents of full trisomy 18 got a karyotype and they were invariably normal. But then I'm going to take invariably out and say there are 2 examples in the medical literature that are case reports of a parent of a child with trisomy 18 who was, quote, normal, but when studied had a low degree of mosaicism. And it had no medical effect. And it was a small percent in the blood, and probably, of course, was also in the cells that form the sperm and the egg. So we don't do chromosomes in parents of full trisomy 18 because we know that we're almost never going to find anything. I mean, that's, again, a statistical thing. But we also know that families of a child with trisomy 18 have an increased but low risk for another child. And that increased risk could be due to a mosaicism in those sperm or egg cells derivatives that we could never find. That's part of the reason why we don't do the blood studies on the parents. So we don't need to do them, but it drives the question that I have a note to make and forgot to make, which is when a family has a child with full complete trisomy 18 or full complete trisomy 13, what is their risk in another pregnancy? And what we know, and there are very few studies, but what we know is that that risk is above the background risk of 1 in 6,000, 1 in 12,000, above the background risk, but less than 1%, less than 1 in 100. So it's, and the reason for that increased risk, I'm repeating myself, could be due to the fact that in those rare parents who have a reoccurrence, there are more than one trisomy progenitor cell there. So again, that was a lot of packed information. Bottom line, parents of focal trisomy have a low, less than 1%, but increased over the background. Consideration of prenatal diagnosis is always valid. As far as the COVID question goes, you know, I could say yes, no question. We still got a long way to go about COVID-19. I'm a great fan of Dr. Fauci, and whatever else we hear about, you know, with all the rest, I know that he's hopeful about the one of the trials, and I know that the NIH is working on implementation as we talk. If we have a safe and effective vaccine before January of next year. But we need to be talking about both safety and efficacy. So we want to know that it's safe, and we want to know it works. But we're not going to get back to what we used to think as the old normal without herd immunity. And 60% of people either have to have antibodies or have to have been immunized to have antibodies. And we hear back and forth. If you have COVID-19, you get okay. We don't know that yet. We'll find out. So I think in some ways we have to wait and see. We certainly would want the vaccine to be as safe as we know, and if we find out, like flu vaccine, rather quickly as we've done, that the COVID-19 vaccine will be safe, I'm going to say yes. So my tentative answer is yes, we have to consider it, but then I have to qualify it because we still got a lot more to learn. I do, of course, as you know, would advocate strongly for all of our children with trisomy 18, 13, any related disorder to continue to hanker down as well as we can, have telehealth visits when we can, mask, you know, out in public when we can, never stop hand washing despite wrinkling up our fingertips, and of the social distancing and all, I mean, everything, right? Because we know that even though children seem to get it less common and have milder versions, we know that our children have increased risk.
Christina wanted to share that her daughter, Sophie Marie, with full trisomy 13 was diagnosed with hypogammaglobulinemia. I hope I didn't totally.
You said it perfectly, Kelly.
Excellent. Last fall, and is currently receiving IQ-IG weekly. She has been infection-free for 12 months following her initial IVIG last July.
How old is she again?
She didn't say how old she is, and I'm not really sure. So maybe Christina will comment back and say how old she is. She's six and a half.
She's 6. And then we had the family from Canada whose child was 5. So thank you for bringing it up, because I again, I guess I'll say again that this needs to be studied better. Our immunologist said to me when I asked about my little friend here in Utah last September that if it would decrease hospitalizations, that he would administer it, and his younger colleague, who unfortunately we lost to another medical center, did initiate in the hospital, and now it's being continued. So that's our Utah patient who's receiving immunoglobulins. And we could say, given we know infections occur, and there hasn't been, oh, by the way, you mentioned something important. You said that she has hypogammaglobulinemia. So she has lower IgG and IgM. Those are the names for the antibodies. We know she has it. No question that we would. The question comes up when if someone does immunoglobulins and they don't find low levels of G and M, and then they might not want to give it. at least our immunologists were willing to give it even with low normal IgG and normal IgM. So that's where the sort of potential conflict is in. But if you have an older child who's getting infections like our mother from Canada described, and I should have said that to her mom from Canada, would probably be worth checking the immunoglobulin levels on the little girl we were talking about. Should have said that then. So we checked the immunoglobulin levels. They're low. Seems straightforward that we're going to give immunoglobulins. And I think if somebody has to squabble with it, we now have this experience with the families I've heard about that are receiving the immunoglobulins, like you shared with us as well. If the immunoglobulins are normal, then our immunologists were still willing to go forward, and some might not be willing to go forward. I mean, there isn't very much of a risk to giving the IV infusion. Sometimes there can be a contaminant we're not going to know about. There is some finite risk. I'm not the one who knows the answer to that question. But it could potentially help even if someone's on the border of having an immunodeficiency. Again, I'll repeat myself again, it's one of these areas that should be studied. Thank you for sharing that. We're past the hour, and I'm okay with continuing as long as Zoom doesn't kick us off.
Yep, we're fine on the Zoom end. I have one more question, it looks like, and it's from Rhonda. And she said, based on your last answer, does this mean that the siblings of a child with trisomy 18 could also have an increased risk of having a child with trisomy 18?
Thanks, Rhonda. Rhonda was our mother from Canada, right? Right. Okay. So I did a study with Bonnie Beatty in 1994, which is a collaborative project with SOFT. And what we did was we did the family trees, and in the family trees, no sibling of a child with trisomy 18 or 13 had themselves had a child with trisomy 18 or 13. That has been very well studied in trisomy 21 Down syndrome. And in trisomy 21 Down syndrome, siblings of the child with trisomy 21 who go on to have children themselves do not have an increased risk of the non-disjunction for their offspring to have trisomy 21 Down syndrome. Since we believe that the non-disjunctional events probably have similar biology, I can extrapolate that and suggest that the siblings of a child with trisomy 18 or trisomy 13 would be at likely not an increased over their age-specific risk. Because remember, all trisomy risk is related to the maternal age risk. So at the age of 20, the risk is 1 in 2,000 for all trisomies lumped together. At the age of 30, it's 1 in 1,000, all trisomies lumped together. At the age of 40, it's 1 in 100, all trisomies lumped together. And we know there's probably similar mechanisms. So I think, Rhonda, I can say that your other children are at low and probably at their age-specific risk. Certainly, if they wanted to have, now that cell-free DNA screening is so widely available, it becomes easier to at least do some screening. But I would think their risk is the same. But going back to Rhonda, what I said a minute ago was actually, since you asked me the question, and I didn't think about it except in the context of after that on immunoglobulins, it might be worth checking your daughter's immunoglobulin levels if the G and the M or both were lower. I would consider having her seen by the immunologist for what we heard about from the other mom and what I mentioned, which would be antibody infusion. It is IV, and again, I have great respect for the National Health System in Canada, and but again, it would have to be that question of coverage.
She responded just saying, thank you so much for your informative and personal answer. We have a question from Aaron Heddick saying, you mentioned the age-specific risk, and I've often wondered about this. I've noticed in the private Facebook group that there are many, if not mostly, young moms.
Right. So I mentioned the age-specific risk, and we'll just there are age-specific. Well, there are age-specific risks for trisomy 18 and 13 for this specific condition, but unfortunately, I don't know them off the top of my head. I do know the overall risk that I mentioned earlier, and most of that risk is really for trisomy 21 Down syndrome, but it includes 18 and 13 together. So the age-specific risk. I'm sorry, I went off on a tangent. I state the second part of the question again for me, Kelly.
She was just making an observation, saying that she's noticed in the private Facebook group that there are many, if not mostly, young moms.
Right. So the reason is that even though your risk at 30 is higher than your risk at 25, which is higher than your risk at 22, that's the case. So your risk at 32 is higher than 30, and so on. Most of the women who are having pregnancies are in their mid, slightly above 20, and are at a finitely low risk. So that's why, even though they're at a low risk, they still have a risk. But that lower age group still makes up the proportion of who has a child with trisomy 18 and 13. So I don't know if that made sense. So we could figure out, I don't know off the top of my head. But in trisomy 21 Down syndrome, I know the figure off the top of my head. 90% of children with Down syndrome are born to mothers under 30, even though their risk is higher at 32, 35, 37. The 34 and 35 and 7-year-olds are making up a small proportion of the total. So that's why when you talk to a group of mothers of any trisomy, their average age is going to be slightly above the average age of women having children, which is like 26, 27. And they're not going to be in their mid or late 30s. So that's a mathematical construct. It's almost easier if I showed it to you on a whiteboard, but I hope it made sense.
She said yes, thank you. So I don't have any more questions that have come in, and I don't see any more hands up. I want to thank you, Dr. Carey, as always, for doing this amazing presentation and answering all these questions so in depth. I know we always, when we get a chance to speak with you, we do always like to pick your brain a lot. So I'm glad that our parents have this opportunity to do this, and even virtually. I want to remind everybody that we do have more presentations coming up. We have Dr. Braddock this afternoon going on at 5 p.m. Central Time talking about tumor risk in children with a trisomy 18. And then tomorrow we have our parent group. So we'll have our mom group and our dad's group tomorrow. You can go on over to the website, trisomy.org, and register for those presentations if you haven't already. Also, somebody just added, Erin Heddick just added, side note, her daughter, Cora, who is 2, receives sub-Q infusions, and she'd be happy to share info if there will be a study in this area.
Thank you. And thanks everyone for your attention and great questions. And you can see, I always envision it, but there's only 24/7 where SOFT can facilitate some of this kind of work. I know Terry and Kelly are on the board. And I think even having the seminars this week to the medical professionals, I'd like to see us be the platform to initiate so much of that.
Absolutely. Okay, I want to thank everybody for coming, and thank you, Dr. Carey. We will have the video recording of this session up within the next couple of days or so, so you'll be able to review it again. And we will see everybody later on this afternoon. Goodbye.